All right, welcome back to our provider development series, and today we're going to continue our sessions on clinical reasoning. As a reminder, in part one, we discussed the introduction to clinical reasoning and why it's important. And today we're moving on to part two, and just to keep things easily digestible in these short videos, we're going to break part two down into two separate parts, okay? But to start off with, part two, we're going to cover how we think, how we learn, and how we apply that knowledge. And I'm going to touch on these concepts both for adults in general as well as doctors or APPs specifically. Now, as a disclaimer, we're going to get into some learning theory pretty heavily, and we have to slog through a lot of different definitions. But I think it's important to kind of bear with me because the things that we're learning in parts one and part two will end up being very applicable to our final two sessions, where we really start to learn some practical ways to improve our clinical reasoning, which is really the main goal of these sessions, is to how do we become better at clinical reasoning. So we're still laying the foundation and the groundwork in these first two sections, and then as we move on to part three and part four, it'll be a little bit more applicable. Okay. Here are our objectives for part two, again, which will encompass two different sections. So we want to become familiar with the different theories that explain information processing. We'll talk about the different shortcuts that providers use to analyze large amounts of information. And we'll appreciate the importance of illness scripts and problem representation within the context of clinical reasoning. Okay. Now, as I said, we're going to be covering quite a few types of learning theories here. Now, over the past century, there's been a lot of different theories proposed because this science has really exploded, over that time. And many theories that have been proposed in the past are now outdated. Many theories have had to evolve. And then there's a lot of others that have quite a bit of controversy. But I'm going to stick to a couple of basic ones that aren't really debated within the world of clinical reasoning. Okay? So the first theory that I want to talk about is information processing theory. Okay, so this is a family of theories that is based on the principle that adults process information very similar to how computers process information. Okay, so the theory emphasizes that attention is needed to bring in new information, that we have to use our short-term memory to manipulate and analyze that information, and then we have to be able to store that information in our long-term memory and be able to use it at a later date and have quick recall. So we have to be able to bring in information, we have to be able to analyze it, and we have to be able to store it. So the same basic principles that a computer uses to process new information. Okay. Now, there are a couple of sub-theories within this information processing theory that fall into that realm. So we have dual cognitive theory and cognitive load theory. Both of these are really important when it comes to understanding clinical reasoning. So let's dive into these a little bit more. All right, so first up is dual cognitive theory. So dual cognitive theory is a way of thinking about how we think or how we approach problems. Okay, so type one thinking makes use of non-analytical reasoning. It's emotional, it's quick, it's automatic and subconscious, and it allows us to execute skilled responses, and it allows us to generate intuition with minimal effort. Okay? It also relies heavily on pattern recognition as well as heuristics. And we'll talk about heuristics more. They're a type of mental shortcut, but they make use of rules of thumb that are used subconsciously, which is important to highlight. It's used subconsciously when we're approaching a particular problem. Okay, so think of brake lights as you're driving. The brake lights on the car ahead of you light up. Okay, really, no matter what else the context is, you should reflexively tap your brakes, right? Or at least be prepared to do so. Okay, so type 2 thinking, on the other hand, is slow thinking. It's analytical reasoning. It's logical. It's deliberate. It takes effort. It requires attention, and it requires self-control, and it takes time. And it makes use of probabilities. We make a lot of our clinical decisions based off the probability of a particular outcome, right? Okay, so think of type 1 thinking as the mental effort needed to drive from your workplace to your house. This is the drive you've done a million times, and say it's good weather and there's no traffic. When you're making that drive, it's almost done effortlessly, right? When you get home, you may not even remember making that drive. Okay, it's almost accomplished subconsciously. Okay, so type 2 thinking is more akin to driving in a rainstorm at night in an unfamiliar city. Technically you're using the same skill set, but one is a lot more intentional and requires a lot more cognitive effort, right? Okay, so as I alluded to, which type of thinking you deploy is based on the specific nature of a task, and it's based on your experience. Okay, so as the problem gets more complex, you're more likely to use type 2 thinking. As you gain more experience, you're more likely to use type 1 thinking, and vice versa. Okay, so let me give you a clinical example. So working through a complex acid-base status problem often takes a lot of effort, and it's deliberate and it's analytical, and you use a lot of type 2 thinking. On the other hand, recognizing a shingles rash is done almost instantly, and it's done subconsciously. If you've seen a few, they're easy to recognize, and you don't really have to think about it. Okay? Now, I do want to point out that this theory does not just apply to making a diagnosis. It influences all aspects of our thinking as a provider, okay, so such as gathering information. Okay, so consider taking history from a patient. Now, this bright young medical student may have to rely on things like mnemonics to serve as a scaffold to help them guide their questioning, right? So there's different scaffolds and mnemonics that students use. One that I've seen a lot is this Codier's, which helps them go through the HPI, and it talks about character and onset and duration and intensity of a particular symptom, right? And it helps them remember what questions to ask. Now, with experience, this scaffolding, these mental shortcuts, these mnemonics become less and less important, right? Because the interview becomes to be guided by reasoning, especially as we gather more and more information. So you think this old vet of a doctor on the right is using mnemonics when taking a history? Probably not routinely, maybe sometimes. Now, when presentations become challenging or difficult, even experienced clinicians will fall back on scaffolding as needed to help ensure that they're asking all the questions that they need to. Okay, and we'll talk more about when we should shift from type 1 thinking back to type 2. So as we get more experienced, as I said, we tend to do more type 1 thinking, though that leaves us prone to error. Okay, and so we need to know when to shift to type 2, knowing that it will result in us being less efficient and it takes more time. Okay, so we'll talk about that, but in general, this was just kind of giving you an idea of how dual cognitive theory works. Okay, and we'll keep coming back to this a lot throughout the sessions. Okay, so let's move on to our next theory, which is cognitive load theory. So cognitive load theory refers to how many discrete units of information we can handle in our short-term memory, okay, when solving a problem. So this is why we're pretty good at remembering a 7-digit phone number. All right, so we can remember it long enough to dial it, and then poof, it's right out of our short-term memory, right? So on average, we can remember 7 plus or minus about 2 different units of information within our short-term memory. Now, how does that work clinically? So the cognitive load theory really takes advantage of what is called chunking or encapsulation, and we're going to talk more about that later on. But say you're listening to a presentation and you hear these terms: fever, hypotension, tachycardia, hyperventilation, altered mental status, warm extremities. Chunking is taking these 6 terms and saving them in your short-term memory and coming to the conclusion that this patient is septic, right? And we do this innately, especially as we get more experience. So this cognitive load theory, or this 7 plus or minus 2 rule, is universal. So what that means is that first-year medical student has the same short-term memory skills as an experienced attending. The difference here is that the expert clinician is more able to chunk what is seemingly random and seemingly non-connected data together. Okay, so allowing them to simultaneously consider more clinical features in order to try to figure out the problem. Okay, so let me phrase it this way. In other words, as that experienced clinician is listening to a history, any new information that falls into the sepsis category, they can pretty much ignore it, okay? Because it fits with that entity that they've created. And so now, instead of this being 6 or 7 different discrete units of information being processed in our short-term memory, it's one. Okay, it falls under the sepsis umbrella. Okay, and so now that experienced clinician, their ears are more in tune to that new information that may be relevant to the presentation, but it's not directly linked to the sepsis picture. Okay, so on the other hand, the student is having to process each and every one of these. Okay, they're not able to link these terms together to form that discrete unit of sepsis. All right, so they take each of these symptoms in the green circles here, and they're trying to form differentials for each one or ask questions about each one. And they end up using a ton of cognitive effort, whereas our experienced clinician immediately groups them together as a single item. Okay, so again, I want to emphasize that it's really important to note that cognitive load ability generally is going to be the same from person to person, from student to attending. It's just that the experts can process the information with much less working memory and much less effort because of their ability to chunk. Okay. Now we're going to dive into that a little bit more down the road, but I think this is a good breaking point. And when we come back, we'll hit chunking along with these other terms. Okay. See you soon.